please interrupt at any time and ask away. So my name is Steve Zucker. I am the Director of Hepatology at Brigham Women's Hospital. I was formerly at University of Cincinnati for 20 years, where I was the Director of Hepatology there. They have a huge transplant program. They do 130 transplants a year, so reasonable amount of experience with that, and hopefully I can answer any of your questions. But I was given the topic of living with cirrhosis, and as opposed to, I sort of thought, when I started thinking about it, and you get into all the nitty gritty, and I think I started to think back about when I see patients and what questions I get asked almost invariably by people and what misconceptions there are out there. So I thought that I would address this topic by just talking about some things that I hear a lot and that are sort of myths about liver disease that I think is helpful to understand and gives you a better understanding of your disease.
I just need to flip that on the side. It's on the left side. There's a little switch. Sorry.
Oh, this one?
Yep.
Okay. There we go.
Yeah.
It's talking to me. So, common myths about cirrhosis. So, the first common myth is that it's uncommon to have liver disease. But in actuality, it's very common. So liver disease right now, if you look, is the 7th leading cause of death in the United States. And it has the dubious distinction of being the one that is growing the fastest. So we are seeing an increase in mortality from liver disease, despite the fact that most of the other diseases, both above and below, are actually decreasing. Maybe suicide maybe being one of the exceptions. So people are in good company. The second myth is that people say, I have cirrhosis, and they think that cirrhosis itself is a disease. But in reality, cirrhosis is just a histologic diagnosis, meaning that it's what you see on a biopsy slide. It's not really a disease. It's really an advanced stage of scarring in the liver, and many liver diseases, it's the liver's reaction to disease, and many liver diseases end up at cirrhosis. But it's just your liver's response to injury by laying down scar. It's not really a disease itself. It's the end stage of what happens in many diseases. So numerous types of liver diseases lead to cirrhosis. And how do you diagnose it? Well, really, these are liver biopsy slides, and I'm not going to quiz you on any of these, but cirrhosis is scar tissue or fibrosis in the liver, and fibrosis is really staged 1, 2, 3, 4, just like, just a simple staging system. So I show the different stages here. I don't know if
there is a laser pointer, but it doesn't work on the TV. You want me to Vanna White it?
Well, I can point to it, but well, you can see so the blue is the fibrosis or scar tissue in the liver, and the pink or reddish stuff are the liver cells. So the number 1 is what a normal liver looks like. So stage 1 fibrosis, there's just a little tiny bit really right in the center of what we call the portal tract. And then as you move to stage 2, you start to see that fibrosis area gets larger, and you start to see little tongues of fibrosis sticking out from some of those central areas. When you get to stage 3, you start to see that the fibrosis connects those little areas one to another, what we call a bridge of fibrosis. And in the last stage, which is 4, so stage 4 is fibrosis is cirrhosis. It's the same thing. And in stage 4, what cirrhosis really is a lot of scar tissue surrounding nodules or round areas of liver tissue that's trying to grow, but it's limited by that scar tissue. So that's what cirrhosis looks like. And that's what the definition of cirrhosis is. So it's really, again, a histologic diagnosis. So then you might ask, well, then I have to have a liver biopsy if I want to know if I have cirrhosis or not. And there's some truth to that. However, it is reasonable to presume that you have cirrhosis if you see certain things in a patient. So we don't, as liver specialists, necessarily need to do a liver biopsy on everyone to know if they have cirrhosis or not, because we can look at physical exam findings, or imaging. So here's an example of a CAT scan. And if you see the liver is on the left side, it's the big sort of white blobby thing. And if you look at the edges of the liver, you see it's very lumpy, bumpy. It's not nice and smooth, and that's what you see with cirrhosis, those nodules. Then you also get an enlarged spleen, so you can see that here. And around the liver, that sort of grayish stuff is fluid or ascites. So this person has cirrhosis just on the basis of imaging studies, and I wouldn't need to do a biopsy to tell that. Similarly, there's physical exam findings that you can see. On the top is something called spider angiomata that you might have heard of. It's a certain skin finding. If you press on it, it blanches and fills from the center out. That's pretty specific for liver disease, as is those palmar, what we call palmar erythema, or the red splotchiness on the palms of the hands. If you see a patient that has liver disease and you see those findings, you can be pretty sure that they have cirrhosis. And the same is true for other aspects, so ascites, so you see the belly is distended. That other picture to the left of that are esophageal varices, so big veins in the esophagus if you're looking on an endoscopy. When this patient is being tested for confusion or elevated ammonia levels, hepatic encephalopathy, if you have those features, then we're pretty sure that you have cirrhosis.
Why do the hands flap with HE?
So what asterixis is, that's the medical term for what we're looking for, is it happens in people with elevated ammonia levels, and what it is transient loss of extensor tone. So when you bring your wrist back, you're extending your wrists, and so you transiently lose that tone, so your wrists flap forward, and then you gain the tone back, and they come back. So it's a very characteristic finding of elevated ammonia levels.
Unconscious, like it just happens.
It just happens.
As they do this, they flop down.
Right, you can't control it.
Is that almost more reliable than an ammonia lab test in terms of HE?
It is more reliable than an ammonia lab test. So ammonia levels are useful in two situations. One is in acute liver failure, where it does predict brain swelling. So it's something that is helpful to measure. And it's also useful in situations where a patient comes in and you don't know much about them, and they're unable to be assessed. So they're they're unconscious, and you don't know why. Checking ammonia level can be helpful. In people who have chronic liver disease or cirrhosis, and they get confusion, checking ammonia levels is not all that helpful because it's a very unreliable test. You can have a normal ammonia level and still be confused from it, and you can have elevated ammonia levels and be completely clear. So it's assessment of the patient that tells you if they have hepatic encephalopathy, not the ammonia level. Ammonia is not useful in chronic liver disease except rare circumstances. So, good question. So, another one, and probably everyone in the room has experienced this, is that if you have cirrhosis, you must either drink too much or use drugs. That's the assumption, and it's why a lot of people never want to talk about their liver disease, because as soon as they open their mouth and say, I have a liver problem, everyone assumes this. And that's just far from the truth. So while it is true that alcohol excessive alcohol use or drug use can lead to viral hepatitis that can cause liver disease. Cirrhosis is just an advanced stage of any liver disease. And if you look, so these are the different diseases that we transplant for, you can see that alcohol is only 15%. Hepatitis C is another, not even a little over 10%. And all these other things, so medications, primary biliary cholangitis, acute liver failure, autoimmune diseases, all these other disorders can cause cirrhosis. And so it's really a poor assumption to assume that cirrhosis is just the end stage of a chronic liver process. So I get asked this all the time. Well, can you just cut out the bad part of my liver and then I'll be okay? And the problem is that cirrhosis doesn't involve just one part of your liver. It is a scar that interdigitates throughout the whole liver. And so there's no feasible way to take it out. And so there's a normal liver on your left, and there's a liver with cirrhosis, and it's all lumpy bumpy throughout the whole liver. And if you look at a histolysis, so you actually take it out, this is what it looks like when they do a transplant and they take the liver out, you can see the whole thing is gnarly. And if you slice it across, you can see that gnarliness or that fibrosis is throughout the liver. So it would be sort of like taking a piece of meat and cut and say, just take out the fat, right? I mean, you'd never be able to do that, and it's the same for cirrhosis. So it's not just one part of the liver. So the other thing I get asked a lot, and I can't, almost daily, is patients come up to me and say, so how much of my liver is damaged? That you get that all the time. And the answer is very difficult to provide because all you know when you have cirrhosis is that you have a lot of scar tissue in your liver. But it tells you nothing about how well your liver is functioning. So your liver you can have cirrhosis and completely normal liver function, or you can have cirrhosis and your liver can barely work at all. So what we tend to use is something called the MELD score, and you've probably heard of this, and this was developed at the Mayo Clinic many years ago, originally for predicting outcome from TIPS, but it turns out that it predicts very well how patients with liver disease are going to ultimately do. And so the MELD score ranges from a low of 6, which is a normal healthy liver, to a high of 40, which is someone who's bright yellow and in the ICU and doing very poorly. And as you can see from this graph, if you look at 3-month mortality, people with low MELD scores do well. And people with, as your MELD score increases, and they did these ranges, then your mortality increases dramatically. And so this is a good predictor of how well your liver is functioning. In this region of the country, patients who get transplanted are generally in the low 30s for their MELD score, to give you a sense for that. This is what I use to try to explain to patients sort of how their liver is doing. And that's why the MELD score is used to stratify patients on the transplant list. The higher your MELD, the higher you are on the list because you're more likely not to do well. And it's a way of trying to objectify, if that's a word, to make objective the decision about who gets the next organ. So that's sort of what we use. So the other myth is that if you have cirrhosis, you will die without a liver transplant. The other, I sort of say, once cirrhosis, always cirrhosis. And people think of that as, oh, my liver's all scarred, and so therefore, that's the ball game. And the liver is able to heal itself to varying degrees. If you have a cirrhotic liver, it's never going to go back to normal. but if you eliminate the driving force, remember cirrhosis is what happens to your liver as a result of chronic injury. If you eliminate the driving force for that, so if you treat the problem, the liver isn't going to get worse and you can actually get some recovery. So here's an example. This is for fatty liver, so people with NASH, stands for non-alcoholic steatohepatitis or fatty liver. And this is a study where they did bariatric surgery and the patients lost weight, which is the best way to treat this. And then they looked 52 weeks later at what happened to their fibrosis. And I highlighted here, but of the people who, depending on how much weight you lost, you can see that fibrosis regressed, got better in people who lost at least 10% of their baseline body weight. 80+% of them had regression of some of the fibrosis in their liver. So they regressed at least one stage of fibrosis. So it can get better. And so therefore, just because you have cirrhosis doesn't mean that it's a death sentence or you can't do well. What you really need to do is treat the underlying problem. I'll give you another example. Here's hepatitis B. So this is a study where they started patients on treatment for hepatitis B, and the different colors represent the amount of scar tissue in the liver. This is a slightly different scale than what I showed you, but the 5 and 6 are cirrhosis. So the dark brown and the purple are cirrhosis. And you can see by 1 year, more patients had less degrees of fibrosis, and the number of patients with cirrhosis declined. And by 5 years out from treatment, you have substantial reduction. So 28% had cirrhosis at the starting point. By the end point, all these people are treated, only 7% did. So regression is possible. It can get better. But the key is to treat the driving force, the underlying disease, and then let your liver heal itself.
Can I ask a quick question with that? So, a lot of people are curious, how long does it take? And I know that there's not one set timeline, but is there kind of a general guideline or?
About how much the fibrosis will resolve?
Yeah, so say somebody's at a stage 3 and they resolve their disease, whether it be losing weight with NASH or curing hepatitis C or treating Hep B.
So this gives you a rough idea. So within 1 year, you get some improvement. Within 5 years, you can get pretty substantial improvement. So I think you could take this slide right here and generalize it to most diseases. If you can arrest the disease, if you can treat the disease so it's no longer active, then regression occurs pretty much like this.
But also maintaining healthy lifestyle post.
Yes, I mean,
yeah.
if you do something else that damages your liver, you're gonna be right back where you started. So you have to prevent any additional damage to the liver. So this I get all the time. Everyone looks at me like two heads. So the patient will see me and they'll say, "Doctor, I have some pain." And I'll say, "Oh, did you try Tylenol?" And they look at me like I'm an idiot. I can't take Tylenol, I have a liver problem. And I get that all the time. Well, it's really not true. Is that acetaminophen or Tylenol is safe in patients with cirrhosis as long as you stay within 2,000 milligrams or 4 extra strength tablets in a 24-hour period. It has never been shown to cause issues or problems in those. And you have to look at other, so if you look at other pain medications, there's bigger problems with those than with Tylenol. So it is true that Tylenol will damage your liver if you take overdose of it. But at regular doses, it's perfectly safe. And then other analgesics or anti-inflammatories have bigger problems when it comes to liver disease. So non-steroidal anti-inflammatory drugs, so the Motrin, Advil, naproxen, those kind of medications, people with liver disease have a higher risk of bleeding from their stomach from gastric ulcers, and it can also precipitate kidney failure, so it can make your kidneys not work well. And so you got to be real careful with those. Narcotics, the problem there is that you can precipitate the confusion or elevated ammonia levels, and also your body doesn't clear those very well because they're liver metabolized, and so they can build up in your system and create bigger problems. So in honesty, acetaminophen, Tylenol is probably your safest bet in liver disease. So here's another myth, is that if you have cirrhosis, you should avoid protein. I don't know if you've gotten that. That's still out there in the real world. So it used to be thought that protein, it can make you more confused, can make your ammonia levels go up. And that's pretty much been debunked. Patients with cirrhosis are generally protein malnourished. And they tend to have weakness and muscle wasting, and so they need protein. You should be taking excess protein, not no protein. So protein intake should be high. This is what patients with advanced liver disease look like. I mean, they look like they're almost skeletons, and that's just from this muscle protein breakdown, protein loss. And so these are the kind of things that you want to eat. These are the healthy foods. So it's the fish, the eggs, the milk, beans. Those are the kind of good foods that will help you and your liver. I get asked that a lot. So I don't know if you have any questions there. Paracentesis also, when fluid is drawn from the abdomen, when people accumulate a lot of fluid, that's a big protein loss. Every time you remove a whole lot of fluid, you're basically sucking protein out of patients. And so you sometimes need to do a paracentesis for comfort, but realize that that accelerates this protein loss and can make people much more debilitated.
So what is the average protein intake daily use?
Yeah, there's not good data. Generally what they do is they calculate it for your height and weight, and then you multiply by, you give an extra 30% on top of that. So you calculate your body's need, and then you calculate an excess, you need an excess of about 30%. That's sort of the general, but each person's different depending on your height.
So if, protein's good, are there foods that should be avoided?
So really, that's a great question. The short answer is no, there's not a liver-specific diet, but there are certain things that you should avoid depending on certain disease states. So if you are accumulating fluid, so if you have swelling in your legs or in the abdomen, if you have ascites, then sodium tends to cause fluid retention, and so we'll tell people to follow a low sodium diet. I am not as strict, and so you may want to come and see me. I'm not as strict as some of my colleagues. So some people put patients on a 2-gram sodium diet, and you say, well, why don't you do that? And I say, because for 2 reasons. One is, if you've ever eaten a 2-gram sodium diet, it's like eating cardboard. It's awful. And in my mind, nutrition is more important than a little extra swelling. In the end of the day, that low sodium diet is not going to make all your fluid. If you're creating 8 liters of fluid a week in your abdomen, taking no sodium in is not going to make it 0. It's going to make it maybe 7.5 liters, but in the end of the day, it's a relatively modest effect, and it's at the expense of nutrition, which I think is way more important. So I tell patients, certainly be cognizant of your sodium intake. Don't eat high sodium foods. Don't add it to your diet, but I want you to eat. That's what I tell them.
Does sodium exacerbate HE as well, or just ascites?
No, not really for HE. There's really not much you can do for that to make that worse.
The hepatic encephalopathy,
sorry.
the easier to say HE.
Yeah. So the other thing is that if you have the non-alcoholic fatty liver disease or NASH, those patients are generally treated by avoiding refined carbohydrates. So diabetes is or insulin resistance is a main driving force for non-alcoholic fatty liver disease, and so the treatment is really the same as if you were a diabetic, whether or not you truly are, and that's avoiding refined carbohydrates. So, but that's that select population. Now, it's a big population, it's a significant number of patients that we see, but that wouldn't apply to someone with other types of diseases. But for the most part, diet is not, there's not a major liver diet except to take in protein. That's important. And usually we point to the fish rather than the red meats. Chicken is better, but that's more for cholesterol stuff. Liver function tests. This drives me crazy. I'm like this lunatic about this, but liver function tests are not tests of liver function. Okay, so when you look at your liver function tests and you analyze them, you probably follow these if you have liver disease. So the ALT and AST, that's a common one that we look at all the time. Those are proteins that live in your liver cells. If your liver cell is injured or irritated, then they leak into the blood and the levels are up. They are markers of liver injury. So if your ALT and AST are up, something's inflaming your liver. But they don't tell you anything about the function of your liver. You can have an ALT and AST that are in the thousands, huge, and your liver can be functioning completely normally. So those are not liver function tests. They are helpful, but they don't tell you anything about liver function, which is why people ask me about them all the time, and I'm like, it doesn't really matter that much. It does, but it's in the treatment of the disease, so you're trying to suppress the inflammation, but it doesn't tell you about function. Alkaline phosphatase, a lot of people follow that as well. That also, so that's a protein that's in your biliary systems, the really small, tiny biliary radicals that you have. And so it tells you if you have bile duct injury, and it can tell you if there's something infiltrating the liver, but again, it tells you absolutely nothing about the function of the liver. You can have a very high elevated alkaline phosphatase and your liver is functioning absolutely normal. So the tests of liver function, what are they? So these are the three tests that we look at that are standard tests, and they're tests of liver function. One is bilirubin. That's what makes you yellow or jaundiced. It's breakdown of hemoglobin from your red blood cells, and everyone is doing that, so we're all making bilirubin. The reason it goes up in people with liver disease is because the liver isn't able to filter it very well, and so it accumulates. Whereas if you have a normal liver, it degrades it and spits it out in the bile. The INR, sometimes known as the prothrombin time or PT, that's a measure of clotting. And the reason we look at that as liver function is because your liver makes every one of your clotting factors except for one, which is von Willebrand's factor. And so if your liver isn't functioning well, your clotting tests can go up. But that tells you about function again. The third one is the albumin, which is the main protein that's circulating in your blood. Albumin is only made by the liver. So if your albumin levels are low, that can be an indication that your liver isn't working well. So these are truly tests of liver function. The liver function tests that the doctors tell you about all the time actually don't.
We do have a question on YouTube. I'm not sure that you can answer it. My PBC has progressed to stage 4 over a 13-year period. Have been on URSO since diagnosis. Can you estimate how long I will be in stage 4 before transplant is necessary?
You can a little bit. So it really depends more on your MELD score. So that can be helpful. So the MELD score tends to increase very slowly at low scores. And then as your score gets higher, it's sort of like an asymptote, so it progresses faster. So if you're starting at a very low MELD, then you're likely to do well for quite a while. If it's a higher MELD, then that would be sort of a lesser time frame. And without that kind of information, it's a little hard to give a specific answer for that question. The other is that it hopes that, so there are predictors in PBC of disease progression, and depending on what the numbers are, there are ways to add agents to URSO to try to slow disease progression. So I need to know a little more about the situation, but it's hard to give a straight answer there.
Thank you.
All right, next, Smith. So if I have cirrhosis, I will bleed too easily. You probably hear that all the time. And that's not true either. So generally speaking, if you take someone with cirrhosis and you admit them to the hospital and you compare them to a general patient admitted to the hospital, the cirrhosis patients are more likely to develop a blood clot in their leg than the average patient. So if anything, people with cirrhosis tend to have a little bit of a higher propensity to blood clot than the average patient. So it is true that some patients with cirrhosis have an increased risk of bleeding. I don't want to tell you that that's incorrect, but it's not true for all the patients. So if you have low platelets, so patients with liver disease tend to have low platelets. The reason is if the liver is, blood is flowing from your spleen into your liver, and if the pressure in the liver is high, the blood is a lot of resistance to flow, then the blood backs up into the spleen gets big, and it traps platelets, and your platelet count becomes low. If your platelet count becomes severely low, generally that's less than 20, then you have a propensity to bleed because the platelets are the component, the cellular component of the blood that helps your blood clot. So if you have low platelets, particularly if they're less than 20, then your risk of bleeding goes up. And generally they like your platelets if you're going to have a significant surgery or vascular intervention to be above 50. So that is true. You also have decreased levels of clotting factors, like I mentioned, but cirrhosis also leads to decreased levels of anti-clotting factors. And so you have to look at the balance.
The gift that keeps on giving.
Right. So you have to look, it's the balance that matters. If your anti-clotting factors are lower than your pro-clotting factors, then you're going to clot, and vice versa if it's the other way. So it's not a straightforward question, and there's a big push now to not over-treat patients who have elevated clotting tests because most of them do not need to be treated. Sorry, it's a complicated point, but I think it's really important because most patients think, oh my gosh, I can't, I'm going to bleed all over the place if I do anything, and that's not true. So this is a big myth, which is, okay, you're going to get a liver transplant, so we open you up, take the old one out, slap the new one in, and you're on your way. And some people really think that that's what happens. But this is what I tell. So if you talk to any of my patients, this is what I tell all of my patients. Having a liver transplant is trading one disease for another. And why do I say that? Because just like in diseases, you will have to take medicines for the rest of your life so your body does not reject the organ. And these medicines cost a lot of money, and they have side effects to them. The second is that you will need to have blood tests regularly to monitor your liver and to monitor your levels of your medications. So, and then you're going to need to see doctors regularly. So you're taking medicines, you're getting blood tests, you're seeing doctors. It's like having a disease. But the goal is that the disease you have just traded for, the transplant, is way better than the one you currently have. And that's almost invariably true. So people do feel very well after transplants, but it's not just a single operation and you're done. So the other myth, unfortunately, and this is a really important point, is that so a lot of people say, oh, I got a liver transplant, now my disease is gone. And that is true for inherited diseases. So if you have an inherited disorder, you have a bad gene, you take a liver with the normal gene and you put it into you, and then you are cured. So examples are hemochromatosis, where these are genetic mutations, something called alpha-1 antitrypsin deficiency, Wilson's disease, biliary atresia, so some congenital disorders. Those are cured with liver transplant. They're gone, you will never have disease again. However, many infectious diseases, so hepatitis B and hepatitis C, they recur in the liver unless you treat it. Now, we have very effective treatment for hepatitis B and hepatitis C, but you have to treat it. If you don't do that, the disease comes right back and you're going to be back where you started. Immune-mediated disorders, so disorders like sclerosing cholangitis or PSC or primary sclerosing cholangitis, PBC, like our call-in patient, or autoimmune hepatitis, those disorders can recur after transplant. So it can happen again in patients, and so you need to be monitored for that. And then there's acquired disorders can recur if you don't modify lifestyles. So for instance, fatty liver. If you get a transplant and you continue to eat a lot of refined carbohydrates and gain weight, you get fatty liver again, and it can happen in the liver and you can end up with cirrhosis again. The same is true for alcohol. If you don't drink, you will do fine. If there's recidivism, then you can damage that liver just like you damaged the original one. So it's not just a straightforward put a new liver in and your disease is gone. It does require monitoring and lifestyle modifications or treatment frequently. Another myth is, I'm too old for a transplant. I hear that a lot. No, I'm too old for that. I can't do that. So there is no absolute cutoff age for a transplant. Yeah, I like that. It's really, the decision regarding transplant recipients is really based on how safely the operation can be performed and how long you can, go with the new liver. And older patients do have, more commonly will have what we call comorbidities or other disorders that make their risk of surgery higher. And so they're going to be looked at carefully, but in the end of the day, it's your biologic age, not your chronologic age. So you can be 50 and look like you're 80, or you can be 80 and look like you're 50. And if you're 80 and you look like you're 50, that's okay. We have transplanted, certainly I can say in Cincinnati when I was there, we have transplanted people who are in their 80s.
Wow.
So, but they were really amazing.
Yeah.
And so that's how the decisions are made, but I think it's where you are in your life and how you look at life, that's the most important thing. A couple other ones. So this one I try to highlight. I don't know if this is really relevant to any of our patients, but I see this a lot and it just breaks my heart. A fatty liver physicians, a lot of primary care physicians do not understand the significance of fatty liver, and they'll tell their patients, oh yeah, you have a fatty liver, yeah, you lose some weight. And that's the end of it, and patient has fatty liver, and I see these people, they come to my office and they have cirrhosis and complications of cirrhosis. And if I look back, I can look back for literally 20 years, and they've had elevated liver enzymes, and they say, oh yeah, my doctor, you talk to them and say, oh yeah, my doctor told me I had a fatty liver a long time ago, they told me to lose some weight, and they didn't lose some weight, but they don't really think about it. And these are treatable diseases. So approximately 25% of the US population is estimated to have a fatty liver. Of those, 20 to 30% will develop significant inflammation, which is progressive. So this is what happens. You get fat in your liver, and then you get what is called steatohepatitis, which is inflammation in the liver, and that leads to scarring in the liver, the fibrosis that we talked about, and eventually you end up with cirrhosis. So approximately 5% of patients with NASH will be cirrhotic. And this is, if you're talking about 25% of the US population, which is, 200 some million people, it's a lot of people out there that have this risk. So fatty liver is totally treatable. You can prevent disease. And so it's really important if someone says to you or your friend or your daughter or whoever, your aunt, that they have a fatty liver, tell them to go see someone about it and don't ignore it. So another myth is that people with cirrhosis need to be careful about exercise. Exercise is beneficial, period. Okay, it's good for you. If you're up for it, you should do it. Conditioning improves outcomes from transplant and shortens recovery time. And there's actually, this is what we used to use a lot in Cincinnati, which is called the 6-minute walk test. In the 6-minute walk test, they basically take you, put you in a hallway and say, just walk up the hallway, down the hallway, as fast as you want, as slow as you want, use a cane, use a walker if that's what you normally do. Stop and rest if you need to, but just see how far you can go, period. You got 6 minutes. If you are able to do 250 meters or better, so that's about half the distance around a standard track in 6 minutes, your outcomes from liver transplant are great. But if you look at the curve, those are the patients that could not do that, so could not walk 250 meters in 6 minutes. And you can see within a year, or maybe a year and a half, they're all dead. So it's very important to go into a transplant with being conditioned, okay? So exercise is very good for you, and it makes a huge difference. We're not talking about running marathons. We're just talking about, a walk, activities of daily living, but you want to keep yourself conditioned, and there's no reason to limit your exercise. The last and most important myth is that hepatologists are party poopers. And it sort of seems that way because we always tell people you can't drink, you can't smoke, you can't do anything, but we're actually happy people. So this is my group. So on the left is the hepatologists, and one is the PA at Brigham and Women's Hospital, and they're just delightful. They're a wonderful group of people. On the right is when we were at the last American Liver Foundation walk. That was our group there, and we're all posing. It was a beautiful day, beautiful time. So anyway, that's my story. I'll stick with it, and if you have any questions.
I have one question. So the idea of exercise with cirrhosis, fatigue with cirrhosis. So why do people become so fatigued with cirrhosis, and how can they is there anything they can do to counter it?
Yeah, that's a tough question. The short answer is no. Mm-hmm. Fatigue is the most common symptom of liver disease, bar none. The vast majority of patients, over 80%, that will be one of their most significant complaints. So there's a variety of reasons for that. Some of it is from that muscle wasting that we talked about, and you just lose strength. Some of it is just it's exhausting, and if you're walking around with a lot of ascites fluid or swelling in your legs or other things, that just makes it worse. The only treatment that has been reported in the literature is something called modafinil, which is a medicine that can be used. It's specifically for PBC, so it's only been studied in primary biliary cholangitis, and it does seem to help with fatigue in those patients. It is very difficult to get insurance approval for that drug. It's actually used for narcolepsy, for pulmonary, problems, but it also does work in PBC. It probably would work in other liver diseases, but the biggest problem, I guess you could try it if you were independently wealthy, but it's very hard without any data to get insurance companies to cover it. That's the only medical therapy that I know. Staying active does help. When you get deconditioned, it's very hard to dig out of that hole. So that's why I do encourage activity. And when we talk about it, I usually say, listen to your body. So if, you don't have to, I'm not encouraging anyone to go out and make themselves exhausted doing, intervals or whatever, or riding a bike for 50 miles, but staying active, even if it's a matter of doing your activities of daily living, go to the grocery store, go get the newspaper down the driveway, walk your dog. Those are the kind of things that are very helpful and will improve your outcomes from transplant when you get there. So I don't know if that answers your question.
Another one, I do feel fatigue, and I have what I call good days and bad days, and I'm trying to kind of feel some correlation between what I'm doing and when those good days and bad days come. I really can't feel anything. I'm anecdotally or superstitiously, I kind of think it's how much protein I take the day before. Could be something like that, but I'm trying to find some rhyme or reason to it, and it has to do with muscles, but I also get cramping, I guess. I can't stretch my arms quite the way I want to, that kind of thing.
Yeah, cramps are common. We don't really have good treatment for it. The best that I've been able to come up with for muscle cramps, so you tend to see it in people with liver disease who are on diuretics. It's not just limited to liver disease patients. A lot of, my wife gets them,
Pickle
she's
juice.
on diuretic, right?
Mm.
Well,
Yeah, but then it's sodium.
Yeah.
right.
What about like tonic water, quinine?
Quinine has been used. So quinine is useful to acutely help arrest a cramp that's there, and there are quinine pills that you can use, and there's some benefit from those. Although, the cramps go away even if you don't do anything, so it's hard to know. Vitamin E, there's some data that particularly in renal failure or kidney failure patients that it's helpful, and I do advise my patients it's 400 units, just a standard dose, and you do see a reduction, so it sort of reduces the frequency of the cramps. It doesn't make them go away completely, and it certainly, if you pop one, it's not going to make a cramp that you have go away, but it does reduce the frequency of them. And I've had some patients report significant benefit from that. I would say the majority say that it reduces their frequency.
Aren't bananas supposed to be good for cramp?
I've heard everything. I can tell you. People talk about potassium, but I've never seen magnesium. Some people give magnesium for that. I'm not convinced that any of those truly help.
One thing my mom found when she had cirrhosis was one day she would feel like a rock star and she would do everything, and then she'd pay for it for 2 weeks. So it was looking at energy as a limited resource. So you might feel like a superstar today. Don't blow it all in one day. You know, kind of hold on to it for those next days, so that way you kind of use it as that limited resource. Definitely do things, but don't try to do everything on your to-do list.
Yeah, I definitely had those days where I'm completely pain-free. It's like, oh my God.
I'm gonna do
I've never felt this
all
good
the things on the honey-do list, and then 2 weeks you're in bed. So
Yeah, I usually my advice, and it's just practical, is listen to your body. If your you're just exhausted, then your body's telling you something, and take it easy. If you got more energy, then yeah, you can do a little more. It's not a problem.
we do it.
So there isn't really any, like his not
That is
understanding why
typical.
is typical.
That is typical, and yet everyone looks. I mean, I see this a lot. Everyone looks to try to find what it is
It's all
that
superstitious,
does it.
though. You kind of, there's no studying
Because you
involved.
want to be able to
Right.
find something, an explanation, so then you can deal with it. But it's very common to wax and wane, and I've never seen anyone or any study that's actually identified why that's the case. But your experience is very typical.
We do have a question online, which I'm happy to answer half of it. My son has Hep C due to drugs. Does this lead to cirrhosis? And then the second half is he has no insurance except state funded, which will not help him. Is there any organization that can help him financially? I have searched to no avail. He is only 29 and extremely tired all the time.
Well, so the answer is that yes, hepatitis C can progress to cirrhosis. It doesn't necessarily do so. Risks alcohol, simultaneous use of alcohol triples the rate of progression, so you really don't want to drink if you have hepatitis C. But there's very effective therapy, and I suspect that we're going to hear how the American Liver Foundation can help. It depends what state, but many states there's support for treatment. The treatment is extremely effective and very well tolerated. But I can reassure you a bit in that the average time, so if you take an average patient, the time from acquisition until you develop cirrhosis is about 40 years. So it's a slowly progressive disease unless you're drinking heavily or you have underlying HIV. HIV, AIDS, or the AIDS virus, not AIDS itself, does accelerate disease progression as well, but in most people, it's a very slowly progressive disease. There's nothing emergent, particularly in a young person, but it would be better. You would be better off being treated and being rid of the virus and being done with it.
To interject on the financial piece, the American Liver Foundation does have relationships with Patient Access Network Foundation, PAN-F, that can help you get coverage. I see you're in Illinois. If you go to stateofhepc.org, and later I will put this in the comments, it does give a report card for each state to say what the barriers are for treatment. So that's a really good resource to check into. But after this is closed, in the comment section, I'll put in links to some groups that can help fund medication costs. And always call our helpline, 1-800-GO-LIVER.
Good plug.
Any other questions? All right. Well, thank you, Dr. Zucker. Thank you very much for your
Pleasure.
time.
Thank you.